The first topic is current perspective on AIDS and HIV. And the second topic is going to be about COVID-19 on the front lines. I think after that, we would not have too many COVID talks. Keep my fingers crossed. So our first lecturer is Dr. Kristen Ries. She is a professor emeritus of internal medicine and a retired infectious disease physician who was at the forefront of treating patients in Utah at the height of the HIV and AIDS pandemic. She received her bachelor's and master's degrees from the Pennsylvania State University and a Doctor of Medicine with honors from Drexel University. She completed her residency and fellowship at the same university and was faculty member on that university as well. She then left Drexel University and went to work or joined the Indian Health Services, first in Rosebud, South Dakota, and then went to Vermilion, South Dakota to serve in the National Health Service Corps. She moved to Utah in 1981 with the goal of treating more patients with infectious disease, arriving the same day that the CDC released a report about a new infectious disease affecting gay men. Dr. Ries initially worked for the FHP as the head of adult medicine and then as a physician at the Holy Cross Hospital, where she created Utah's first comprehensive HIV/AIDS program. For many years, she and her physician assistant were the only medical professionals willing to work with HIV patients in the state of Utah. They found creative ways to serve patients and provide them with the expensive drugs which were then being used to treat HIV/AIDS. They worked with the nuns at Holy Cross to set up end-of-life care network because the nursing homes at that time refused to take dying HIV patients. In the early 1980s, patients diagnosed with AIDS had a life expectancy of 6 months. We know that's not the case anymore. The refusal of healthcare professionals to work with AIDS patients was a national problem at the time, but Dr. Ries decided to take it head on and make a difference in HIV/AIDS patients' lives. So when Holy Cross Hospital was sold in 1994, becoming Salt Lake Regional Hospital, Dr. Ries joined the University of Utah's Division of Infectious Diseases, where she set up the HIV clinic, now known as Clinic 1A. In 2000, she led efforts to establish a treatment clinic in St. George, which continues to serve patients today. She was the president of the medical staff for the University of Utah Hospital and Clinics, and served as the clinical director of infectious diseases and HIV at the University of Utah. In 1988, she was named one of Newsweek's magazine's unsung heroes. She had been recognized by the University of Utah School of Medicine, the Utah Department of Health and Human Services, People with AIDS Coalition of Utah, Salt Lake County Health Department, and the Utah Medical Association. So bearing that in mind, I figure that there is no better person to give us the talk for this afternoon, the current perspective on AIDS and HIV. Could we please welcome Dr. Ries?
Thank you very much. 2 years ago, she called me and asked me to speak at this convention. And I had such good thoughts about the last time I spoke here, there was no way I would say no. I was so impressed the last time, and now, having seen this film, so very impressed, because if there's one thing that I can do right now, I'm older than the society here. So I think that film is fantastic, and I hope that a copy of that is given to the Eccles Library up at the university, because they're working very hard to have a very special section on the history of medicine in Utah. And they want it to be all of the Utah and to be a resource center for researchers. So thank you so much for that film. And one other thing is, now I have something to think about when I hear the name Dumke, instead of just, that's the Dumke building. So that was wonderful. So it's after lunch, and feel free to go to sleep. There's no notes to take, because this is more of kind of a history lesson. And if there's one thing I've learned since I retired, which is wonderful, by the way, is that history is very important. But when you hear one person speak about history, you only hear one part of the story. So I can only give you my part of the story. The one thing I do want you to write down, if you're interested at all and still in practice, is that the New England Journal of Medicine, September 9th this year, under the case reports, which usually have such erudite diseases that we've never heard of them, has a really good case report of a young man and how they started him on pre-exposure prophylaxis for HIV, which I think is the future. And since we have no vaccines or anything like that, is how we're going to do away with this disease. So it's worth reading if you have any thoughts of doing pre-exposure prophylaxis, or do it, because it presents it in such a nice way that even I can still understand it. Do I just push the red button? Green button. Okay, I'm colorblind, so okay. Okay, so this is a little aside because it tells me how I got into HIV in general, because as soon as I heard about HIV, and it was true that I drove here down Emigration Canyon exactly that same day the report was published, I always think about one of my favorite loves, and that's new viruses, how people responded. And this came from my childhood growing up near Philadelphia, where the physicians all left town when the yellow fever epidemic came. And I always had that story in childhood, and I love epidemics. So I just wanted to mention, sort of like the last time, I'm sure I said, one of you in this room may be the very first one to see the next epidemic that's coming. I'm sure I said that back, I think around 2007 or so when I was here last. And I'm still saying that. You have to always be on the alert that you may be something new that's just not in that medical record system yet. It could be named after you. So even though I'm retired, I still get a lot of phone calls about, is my physician doing right with me, et cetera. And so 3 phone calls this week, 2 from Utah, 1 from Oregon, was, what about the Nipah virus? Do I need to be worried about that? So I just thought I'd throw a slide in there to think, why would somebody worry? So the case fatality rate is very high with the Nipah, and it has a small imprint in East Asia. As you can see from the slide, there's been very few cases so far. And I think that one has to think about how one gets this virus. This also originates from bats. And remember, we should not do anything to get rid of bats because they're very valuable, and especially with the climate changes and everything, we need them for the farmers, et cetera. But it's interesting, as we are encroaching on everything, we're going to see more and more of these zoonoses. But unlike SARS-CoV coronavirus 2, This virus is spread by bodily fluids in bats. And I think you shouldn't drink too much raw date palm juice, because that's one of the ways it spreads in India and other areas. So I don't think we have to worry so much about this coming here, except you have to always remember about travel history. Because of Utah, everybody wants to come to Utah because it's a great place. So I just mentioned it so you at least be aware about it, just get a history, because it can have a long incubation period. And it spreads by excretions, etc., so unlikely to cause a big epidemic like SARS-CoV-2. Can I just have somebody change the slide? I'll just tell you, that'd be easier for my old brain. So I just wanted to give a broad brushstroke about the ongoing HIV pandemic, which continues, and it's been 40 years. Can you believe it? I spent half of my life with HIV, more than anybody else. And to make some things and comparisons about the SARS-CoV virus, because I think there are some. Next slide. Why do we call something a pandemic? And I think recently with this new SARS epidemic, everybody's talking about the influenza epidemic in 1918. My parents had that. But there's all these other epidemics that I've mentioned on the slide. And I'm just going to get these notes up so I can see them easier without bursting your ears. So you have all these other epidemics, and they've been big, but nothing like what we have now. This SARS-CoV-2 is huge. But in numbers of cases overall, worldwide, we have to think that HIV was a huge epidemic, and it's still ongoing, and there's an interaction with this new virus in that people are not worried about HIV. The average citizens in the United States thinks HIV is gone and that we don't see it anymore. But I'm sure you're seeing it, especially since I heard this morning in that wonderful talk that you're looking at STDs, because there's always been a lot more of that in Utah than people believed. So you can look at all these things and know there's always going to be another epidemic. And as we get more and more people encroach on other animals' lands and the climate change, someday, if the climate changes enough, we'll have dengue here. So let me get on with the HIV pandemic. It's true, 40 years ago, Michael Gottlieb described pneumocystis pneumonia in young gay men in Los Angeles. And he became a great help to me because I didn't know who to call because no one here in Utah knew about it. And the university and the health department told me that they weren't going to get into it because it would never amount to anything. And it's true, we are a low incidence state, but I think it's because we have done a good job of trying to stay that way. So where did HIV come from? I think that's really interesting because it probably came from chimpanzee to man, and it probably transferred multiple times before the epidemic really got going. And it's really multiple epidemics. It's all the subtypes, which we know more about now and talk about with now the new Delta variant and everything. And it probably is even transferring now. But I don't know how we would pick it up unless you're doing a lot of molecular genomics. And we didn't have them back there. But it's fascinating that in this epidemic, it took so long, and many people say, well, why didn't you do this or why didn't you do that? I think the new science of genomics and all of these things have changed everything, and it's part of the reason why we could do everything so fast with the SARS. Now, how did HIV get to the United States? And there was this really good article published a little while back now about it probably did first come to Haiti. Now, those of you with gray hair, and it takes a lot of it to remember, in the beginning, we didn't have any tests or anything. We just knew what the disease looked like. And we didn't even know we were looking at disease that the people probably had for over 10 years, a lot of them, and just came to our attention because this disease was probably spreading already in the 70s. But you all remember, we had a syndrome, and one of the things was you had to either be homosexual, a hemophiliac, a heroin user, or from Haiti. And everybody said, well, what's this Haiti thing? Well, it turns out a lot of this probably did come from Haiti because it came from Africa to Haiti and then to New York and then spread around the country. It's a really interesting article to read because the molecular genomics has really changed everything. Next slide. Next slide. I forgot to say next slide. Next slide. Next slide. I'm sorry, I remember that now. So in the beginning, like in 1983, each dot here had so many cases, we hardly saw any HIV/AIDS in the United States. But I already had seen my first case by 1982. At least I was pretty sure of it, because a young man came to my office when I worked at FHP, for those that you remember. And he kept getting gonorrhea. And I was very concerned about him because after about the third time, he came in with generalized lymphadenopathy and a rash. And this is in '82. And so I called the health department, and they said, well, we're not going to get into that, but that's okay. This young man is a young man that I just spoke to 2 days ago because he wished me a happy birthday. And he's still alive after all these years. By 1985, next slide, it was spreading, and it kept spreading. And no one wanted to get that area interested in it. So in 1981 to 1985, it was just a syndromic thing. And it was a sad tale in our medical people that unlike with SARS-CoV-2, nobody wanted to tackle this disease. After many years and a little more gray hair, I understand now that the doctors were truly afraid. They didn't want to take this disease home to their family. And we see some of that now, which epidemics don't change over time. So it was stigma, fear, discrimination that caused all this. And even Haitians were discriminated against. And being in private practice of infectious disease at Holy Cross, I ended up being a hemophilia doctor because the hemophilia clinic decided they didn't want to treat these people either. I ended up being a transplant doctor for those that got HIV from blood. And it was really very interesting at the time. And I don't know what I would have done without Dr. Lombardi, the pathologist, who was also interested. And we spent every morning looking at the slides and stuff of the patients. The disease was named only in 1982, and it was called AIDS. But nowadays, especially this year, we're dropping the AIDS part of the disease, and we're just calling it HIV, which it should have been all along. By 1983, a couple of years after the discovery of the syndrome, the virus was found, both in France and here, and the World Health Organization started tracking it. And by 1984, Margaret Heckler, who was an important government person, said, we'll have a vaccine in 2 years. She just, so we all said, okay, 2 years we'll have a vaccine, and we were all for it. By 1985, we finally got a blood test for the disease. So for the first 5 years, we had no blood test or a way to know who might be having the disease. And that's when we found there were so many people that had the virus that didn't know they were sick, they had no symptoms, and that's why it was spreading. We did know, however, in 1981, 1982, in the very beginning, that this virus was spread and how it was spread. So everybody said, weren't you afraid? Well, I am dumb, but I'm not that dumb. And so I was not afraid because I took proper precautions. Because we knew it was spread by blood and sex, etc. That's why the hemophiliacs got it and no more. So by 1985, next slide, there was a big bunch of people with the disease. And AIDS was the big problem, and the big problem was opportunistic infection, but the biggest problem all was end-of-life care and stigma and all these things that went along with it. And as caregivers, we had to learn to do all these things ourselves because no nursing homes, no home health, or anybody would ever see it. As it turns out, it was really a good thing because Maggie and I used to make house calls anywhere from Brigham City to Provo. And so I really got to know Utah and a lot of the things about it. Plus, we learned a lot about house calls and how valuable they were and how easy it was to take care of the patients with the help of their families and friends. Next slide. I'm just showing this slide for those of you that might be a pathologist or be interested. These pictures, all but one, were taken from my personal patients, and they show all the possible opportunistic infections that we used to see. And many patients had 5 and 6 of these all at once, and it became very complex. It might have started with the pneumocystis pneumonia, which is in the center top, but it changed, and we learned all the other things. And when we learned it was the T cells, we looked for all T cells diseases that we could see. It was unbelievable to see all the malignancies, the Kaposi's, etc. And it was a full-time job working with the pathologist and anybody that would help us. And I must say, when I went personally and asked any doctor, they always helped me in the end, although they were scared. But I always, part of my job was always to educate people about how to take proper precautions. And it worked. The next slide. By 1986, Zell McGee up at the university, some of you may remember him, he invited me to come to the Infectious Disease Conference and present my patients with HIV/AIDS because they didn't think they had seen but 1 or 2. Well, by then I had seen 48 patients, and 46 of them had died. It wasn't until much later that I realized the effect that had on myself and the caregivers I worked with. But we already know that about the people taking care of the COVID. The virus in 1985 was officially named the human immunodeficiency virus, and there was a start of AIDS treatment units. The nearest one here is in Denver, and AZT trials in 8 cities started in '86. Of the 46 patients I had that died, the average age of these people were young men, 33, all younger than myself. If they had pneumocystis and all the other things, they tend to have a life expectancy of maybe 12 months under our care. If they had Kaposi's sarcoma as a presenting symptom, they seem to live longer, 18 months. All the things that happened back then were people in the arts that helped us. There's a huge amount of art that came out of this epidemic. And actually, I have a lot of it from local artists and donated them to the Marriott Library at the university. Would you believe it, back in '86, the Justice Department ruled that you can fire people with HIV/AIDS, and many of our patients were fired. So, in general, the best insurance I could ever hope for is that everybody could get on Medicaid. Because in the beginning of the AIDS epidemic, the patients were of all socioeconomic levels. It's changed since then. But if they were insured, they soon lost their insurance. And we ended up filling out papers so Medicaid could pay after they were dead. In 1987, the FDA approved AZT. You have the next slide. And there was a lot going on. The US shut down any immigration from people with HIV/AIDS. And then all of the HIV major international conferences and all were moved out of the United States to other countries, and they wouldn't meet here again until most recently. By '87, 7 years into the epidemic, Sister Joan and Sister Linda from the Holy Cross said, "You know, you're dying. Nobody will cover you. You can't get help or anything." So they helped to set up this dedicated unit, and we had a 10-bed unit. I didn't know till most recently, as we're doing the history of HIV and AIDS, Dr. Beth Plenick from the history department is writing a book. She's getting fairly along with multiple oral histories, et cetera, is that the doctors weren't too happy about that in general because they thought it would hurt the hospital. At that same year, the state of Utah, they're about to meet again soon, passed a law prohibiting people with AIDS to get married, which doesn't make any sense at all. And one of our patients, Cindy Kidd, and another patient fought that and won. The next slide. By '88 to '89, we had development of multiple drugs for HIV, all of the nucleosides. Now, there's a debate, and you even talk to a young doctor, and they will say, AZT didn't help. Well, AZT did help. The problem was we used it alone. We didn't combine it. We learned later you had to have multiple combination therapy or different drugs. So we just started AZT, and then when that failed, we switched to another one and another one. And as we know now, especially with the COVID virus, that these viruses are constantly mutating. And as everybody said so well this morning, you can't predict the future. As much as very intelligent people, smarter than I, think they can, we can make a guess where things are going to go, but we don't know. So we don't know the future a lot of times, and we didn't know then until we finally, later on, got really good therapy. But I can tell you that our patients that were dying in 6 to 18 months were living 2 to 3 years if they could take the drug. But the drug cost $10,000 a year, and they're all uninsured, and nobody wanted to pay for it, including FHP, Intermountain Health, and all the insurance companies didn't want to pay for it because it would attract those patients to their plan. So I learned an awful lot about insurance and how things really worked. It's hard to believe that the pills that we gave those patients had such terrible side effects. Neuropathies, some caused diabetes, wasting. I mean, it's unbelievable. And just the usual GI upsets and everything. And it's also hard to believe that everybody said with those young people dying in pneumocystis, well, why didn't you just give them trimethoprim sulfa? That's easy. It was around. Well, we didn't know that then. We didn't have trimethoprim sulfa approved to treat pneumocystis until 1988. We had to get pentamidine from the CDC to treat people, and you all know that's not an easy drug to give. But by 1989, the CDC released pre-exposure prophylaxis for people that get exposed. And so I certainly had a lot of phone calls from my less agile colleagues who stuck themselves. And we treated an awful lot of people with AZT. And one of the most important things that ever happened was learning that you can treat the mother that has HIV with AZT, and it would prevent disease in the baby. And Utah's never had a case since we did that. And so, to be honest, now I can say that some of us in the practice started treating with AZT and had the mothers decide if they wanted to try it, not knowing if it would cause a defect in the baby. So we started actually treating our mothers years before it was approved. I would never do that nowadays. I think I'd be in big trouble. Ganciclovir to treat HIV was not available till 1989. And the reason I go through all this is because I think history is important. Young people may think, well, I'm learning all this, and I know they say I have to keep learning because it's going to change forever. I don't know if we're going to get another big change since molecular biology and everything is in such use nowadays. And in fact, I've just been reading about CRISPR, which is just so exciting. But it probably will change just as much, and I can't even imagine it. So ganciclovir didn't come available to treat the eye disease because cytomegalovirus causes retinitis. So we also had to learn about blind people because we had a lot of blind patients who went blind from the disease. So that was a whole new thing to work with Dr. Christiansen, who helped us a lot with the idea of eye treatment and low vision, which he was still is so good at. We also had an inordinate number of deaf patients because people that were deaf at the time did not get the message like everybody else did. So I never learned sign disease. That was more than I could do. But all the people that helped us, the artists, the Utah AIDS Foundation, and all these things, not as big here. Like ACT UP was here, but it never got really big, like laying down. I remember being at the AIDS conference in Berlin, where they threw beet juice all over Dr. Fauci and the people there because they were so mad at him. So there was a lot of things happening, including Jonathan Swain, local grandson of an AIDS patient, who wrote a book, and he's very famous in Japan, where they loved his book, I Am Jonathan and I Have AIDS. Next slide, please. I'm just touching on some of the things that stand out. So you can see by 89, the cumulative cases are just growing. And next slide. Next slide. And the next slide. And by 1990 to 94, we finally got the Ryan White Act, which was so helpful because it gave some funding to take care of all of these patients. The American with Disabilities came around and said HIV was a disability. And in 1992, this will sound familiar, the FDA gave their first accelerated approval for a new drug for emergency. And that was amazing that they did that because the AIDS activists really worked with Dr. Fauci and a lot of these other people to make that happen. It was really our patients that made so many of these things happen, and that has changed everything because we have all these accelerated approvals now for COVID. About that same time, Dr. Woody Spruance, who's a great infectious disease guy here, started drug trials because he had an in with a lot of the pharmaceutical companies. And of course, the university didn't have hardly any patients, so he came and ran them out of our office, which is actually very helpful because a lot of the patients could not afford the drugs, and so they couldn't get them. And that might sound familiar to today, to take care of people that are less advantaged, and people that, even with cancer and everything nowadays, who can't afford to get the drugs they need. It was only during that time that the trials showed that 2 drugs worked better than 1, and then 3 better than 2, because it prevented the genetic mutations from breaking through. And that really made a transformation in how we treated patients. So we started doing better. And then in 1994, we got treatment for AZT for prevention. And unfortunately, the Holy Cross Hospital sold. And actually what happened there is that the new owner came to me and said, "We don't want you here anymore." But luckily, the university had been trying to get me to come there for a long time because they really wanted an HIV program. And so we upped and moved ourselves and like over 500 patients to the university. And that really worked out very well. By 1994, we also got our first protease inhibitor. Next slide. And we were able to expand the clinic at the university. And one of the most important things was to get a dedicated PharmD. I personally would never practice medicine ever again without my own PharmD or somebody. In the beginning, with all these drugs, we didn't know much about drug-drug interactions. I think the pharmacist did, but it only was certain very obvious ones that as a clinician we would know. But it has been really wonderful, and Christine Jamingen joined us, and she left for a while and then came back, and she's still there today, and she's a wonderful resource at the University Clinic 1A. I think if I got HIV, I would go to Christine for treatment, because she's got it all figured. By 1995, we had our first non-nucleoside, and so we had, 3 sets of drugs: nucleosides, non-nucleosides, protease inhibitors, and that changed everything, and they called it the Lazarus syndrome. We had people that were really on their deathbed, ready to die, skin and bones, and I must admit, having lived through the end of World War II, I saw that there was a big problem. So I just really was so impressed. Next slide. So we got more and more drugs. We got more and more into prevention. And where are we now? Well, we have a really whole thing. The whole idea is to get a patient, treat them immediately upon diagnosis. This is failing because they can't pay for the drugs. But hopefully we can do better in Utah. And then make sure they're taking the drugs and following up with all their appointments, and that their virus load's undetectable. Because we know, next slide, that if you're undetectable, you can spread the disease, and we can see remarkable changes. Next slide. HIV is very complex nowadays because we have people from all over the world and here that are now 40 years into their illness. And we can see in the next 2 slides, if you could just go through them, the epidemic has changed completely. It is now the disease of the disadvantaged, the uneducated, the uninsured, and certainly African Americans and Hispanics compared to what it was in the beginning. It's mostly in the South and some other in the North, but mostly in the South And there was a huge outbreak in Indiana, Tennessee, Kentucky area this last year. Go on the next slide. So where are we now? There is probably not going to be another vaccine. The last vaccine trial just ended as a failure. So we know if you're undetectable and you're taking pre-exposure prophylaxis, and we're getting rid of the stigma and everything, that you can live forever and not spread the disease. Next slide. There's so many pills available nowadays. One pill once a day, and now there's a shot available. Next slide. Next slide. So the vaccine, I'll skip that, but it's in your handout. It's not going to be here. How has SARS affected this? Next slide. This is very telling that the UN AIDS target that was projected, and even here in the United States, is not being met because all the epidemic of COVID. There's less PEPFAR after the last administration. There's huge problems. So we've lost ground, but I have hope. I think we're going to do better. Next slide. The antivirals are really almost too many to count. So I don't know if we're going to have a vaccine. Dr. Fauci, in his interview with National Geographic, just said he doesn't think there's ever going to be a vaccine, and that's possible. But if we can just keep people undetected and go on with that, I think we can get rid of this epidemic, and mainly it'll happen in first world countries first, like the United States. But we have lots of antivirals, and I think we can control this disease with that, and if there's a will. What I would like each of you to do, to consider, is to make sure you take that history that he was talking about this morning of HIV and testing, and also ask your young patients, or any patients, are they at risk, and if they are, learn how to do pre-exposure prophylaxis, because I think every doctor could do that. I'm not going to tell you what drugs to use and all, because it's all in flux, and you can always find out if you decide to do that. But I don't see why that the average doctor can't do that and follow up the patients. And that article I mentioned is perfect to tell you how to go about doing that. So that would be my thing, is to find the people that have it, and particularly find the people that don't have it and prevent them from getting it. And I think that could change the HIV epidemic, first here and later overseas. And I want to thank you for your attention, and I hope that this was of any use at all. Thank you.